again in India. I've been a few times. Fascinated by your great nation, and congratulations on all your progress in economy, science. You should be proud of yourself. Thank you very much for inviting me. Manoj asked me to talk about lipodystrophy and autoimmunity. I'm not going to talk like rocket science, but I thought this area is a little bit neglected, and I hope you will find it interesting. I didn't know much about this condition, and I'm sure you might be saying, this is too rare. Why are we hearing about it in such a conference? And my answer to that, if that's the way you're thinking, yes, it's too rare, but it's quite a bad metabolic condition that I thought I will share with you. I didn't know much about it until the last few years when I got introduced to lipodystrophy through some families that I have met. In fact, one of our publications was out just last week in Hormone Research in Pediatrics, and I'd like to share this case with you because it's really fascinating. This is the comment from mother of that child who is adamant that her girl is cursed. This is nothing to do with medicine, she says to me, but there's something really wrong in terms of evil spirits that's happening to her child. Before I go and present the case, I would like to tell you just a tiny bit about lipodystrophy, just to refresh your memory. So it's a rare disease, but it can be quite life-threatening, and it's valid for such a conference because of its large impact on insulin resistance, hypertriglyceridemia, and diabetes mellitus. And it's very interesting because what happens is there's redistribution of fat. So people lose fat from wherever the fat is, and it gets accumulated in the wrong places, leading to these metabolic effects. So again, in line to what we have been hearing about the abnormal metabolism and the cardiovascular risk and the fatty liver disease, this is basically what happens with the severe comorbidities of lipodystrophy. So liver, we get hepatic steatosis, kidney, glomerulonephritis and proteinuria, heart, cardiomyopathy, atherosclerosis, and pancreas. Interestingly, with the elevated deranged lipid, we get repeated episodes of pancreatitis, in addition to the rest of the hyperandrogenemic features manifesting as infertility and lipodystrophy. One major issue in lipodystrophy affects the brain, so it's related to leptin and leptin deficiency. So leptin deficiency in this condition leads to decreased satiety and significant hyperphagia. So I don't know how many of you have seen patients with lipodystrophy. I haven't seen many, but we managed to see a few. In the Arab region where I practice, there's a lot of consanguinity. I'm not sure to what extent that is the case in India, but we do see lots of autosomal recessive conditions. So I was lucky to see some of these fascinating patients. So lipodystrophy can either be generalized or localized. It depends on the way you classify it. You can classify it as generalized, and under that it goes congenital generalized or acquired generalized. You can also classify it as partial, where it goes as familial or acquired, and there's no actual distinction in terms of clinical features to take you here or there. So if you look at these, for example, patient number A, you see how lean this person is around the limbs. And patient number B, you can see some accumulation of fat in the tummy and in the neck, and then very lean at the buttocks and the legs. Patient number C has accumulation of fat in the tummy and quite hypertrophy of muscles and lack of fat in the limbs. And patient number D, you can see the accumulation is fat. is in fact in the thighs, and there's absence of fat in the limbs. So it's quite fascinating clinical picture, and each of these abnormal fat distribution leads to specific position in the category of the patient. So this is, for example, the generalized lipohypertrophy. So you have one on your left-hand side and another one on the right-hand side. And you can see the distinguished feature of the prominent muscles and the absence of fat and accumulation of fat in other places, like in this case in the liver and in the spleen. Patients develop severe insulin resistance, and as you can see, there is a deep acanthosis nigricans and xanthomas, indicating the wrong distribution. And this form is the partial one. So you can see that lady in the middle, she had lots of fat around her face, neck, and tummy, but she has nothing in the limbs, and the opposite with the other lady. A very cardinal feature of lipodystrophy is hyperandrogenism. So you see the abnormalities in the ovaries and in the acanthosis nigricans. And there is a way to put your differential diagnosis, because you might say, okay, well, we get loss of fat in scleroderma, for example. That's not what I'm talking about. You get loss of fat in HIV. This is, again, not the condition. You get loss of fat in progeria, where the patient has those senile features. What I'm talking about is the lipodystrophy, which is either associated with the autoinflammatory or after exclusion of HIV and others. So let me take you through the case I was asked to present. So these are just some of our publications on lipodystrophy that has been recent between 2024 and actually the middle one that I'm presenting today, or actually the bottom one, is the one that came out last week. So let me just tell you this story of the child whose mother thinks that she is cursed, and she doesn't believe that this is medicine, and she stopped coming to doctors. So this is a lady who presented at 2.5 years of age. These are photos for her when she was younger, just a normal child like any other one. And then when she presented, mother said that my daughter became very slim, but only around the legs and arms. And then this girl started accumulating fat, so her abdomen was looking significantly distended. Parents are first-degree cousins, and she has 2 other healthy siblings. So I got some photos for her just to show you. And if you write from your left-hand side, so you can see that her limbs are becoming very slim, and her tummy is becoming distended, so having a very sort of specific physique. And if you look closely to her buttocks, you see those areas with lipodystrophies, like holes in her buttocks. She doesn't have diabetes, and she doesn't inject insulin, because some of us have seen this thing as lipodystrophy in patients who do not rotate injections. But that's what happened with this girl, completely spontaneously, with no any triggering factor. And you can imagine, I met her when she was around 12, and she had significant body dysmorphia because she was completely skinny around the limbs, and her tummy was very hypertrophied. Something that made her even more concerned about how she looks is the muscle bulk in her limbs and her veins. The veins around her body became hypertrophied and looking like those of footballers. So she wasn't very happy about that. She had significant acanthosis nigricans, as well as in her neck, as well as in her axillae. Now, despite this dramatic clinical features and phenotype, her metabolic investigations were not that bad. Yes, a little bit of derangement of her cholesterol, but her HbA1c was normal, her LFT were normal, and her leptin level was normal too. So we thought this must be genetic. Let's do the genetic testing. So we did an extensive panel for lipodystrophy, and everything came back negative. But this is next generation sequencing. So people said, oh, is this something acquired? It is not genetic. But again, remember, in the panel of genes, you need to remember there are limitations. We could have missed some underlying genetic condition because the analysis does not actually exclude any variants or in regions that we didn't examine. She could have deletion, she could have insertion, so we don't really know. If you have any idea, please do let me know. So let me take you through her progress. So she presented at 2.5. At the age of 4 years, she developed alopecia and vitiligo. And when she was 12, she presented with exophthalmos and swelling of upper eyelids. And she had a clear-cut exophthalmos and biochemical features of Graves' disease, having suppressed TSH, high T3, T4, positive antithyrotropin antibodies, and diagnosed with Graves' disease, started on antithyroid treatment. Now in pediatrics, I am a pediatrician, we do see Graves' disease, but we don't see as much as you guys do in adults. We don't see those complicated Graves' orbitopathies, and I was a bit nervous, I must admit, managing her, because one day she came suddenly to the hospital saying, I can't see a thing. And I said, oh my God, what's happening? I haven't seen this in Graves. Perhaps this is migraine. That's what I thought. And she's having amaurosis buccax. But then I learned with colleagues from adult endocrinology that this could well be a feature of Graves' oculopathy. So I obtained an ocular MRI, and as you can see, perhaps there, her extraocular muscles are very bulky, and she started having this sudden vision loss when she gazes to a certain direction. So severe Graves with significant oculopathy. And she was started on steroid treatment. So this is a girl who had alopecia, she had vitiligo, she had Graves' disease, she lost hair fat all over her body and got accumulated in the tummy, started getting some metabolic derangement, but it didn't stop there. And that's why mother thinks that somebody is putting some evil spirit on her, because every now and then she come up with a new disease. And then at the age of 14, she started to pigment. She used to be similar to my color, and then she started to look much darker and darker, as if she was turning black. And then her mucous membranes, so she stuck her tongue out, and there were those hyperpigmented area, and she failed her synaptin test. So another autoimmune disease has developed on this little unfortunate young lady, and we started her on steroid replacement. Her growth was okay. She went into puberty all right, and she had spontaneous menarche. Her leptin level remained normal. So I don't know how you feel, because at some stage I was thinking about this evil spirit and what mother is thinking. And then I said, okay, well, I've done 20 years of pediatric endocrinology by now, and we know that multiple autoimmunes do exist, and especially with lipodystrophy. So now, for those of you who used leptin treatment to treat leptin deficiency, I would like to remind you of what leptin is. So produced by adipose tissues, it has quite a short half-life, but it has a lot of peripheral effects, and that's why people with leptin deficiency, they use it and they manage to lose weight. The question is, will it be beneficial if I use it in this girl. Let me tell you something else about leptin. So leptin has been approved not only in leptin deficiency and severe monogenic obesity, but it's also FDA approved for congenital and acquired lipodystrophy. It's also EMA approved. So I could have used it. And leptin in these people is not used for treating obesity, because even though they have hyperphagia, they are not necessarily obese, but it's used for the metabolic effect. So we've heard lots about pioglitazone. We heard a lot in this conference about insulin resistance and how to treat it. But leptin has been proven to work in people with lipodystrophy who have a lot of metabolic defects. My problem with this girl is not the metabolic defects. My problem is with the abnormal fat distribution, giving her that body dysmorphia, as well as the multiple autoimmune diseases. This is an example for metroleptin used in congenital lipodystrophy. And you can see these are the 5 people who are treated, and you can see each one belongs to the one underneath it, and it does work. If you have it, we do have it in Abu Dhabi, but I wasn't sure that it will be beneficial for this child. So I hope I managed to stimulate some thinking in you about this rare disease, lipodystrophy, and I'd like to remind you that it does exist and coexist with multiple autoimmune diseases. So this girl remained on carbimazole for Graves' disease. She remained on multiple steroid replacement for Addison disease. What I didn't know why, and I would love if any of you can tell me, even after I replaced her with steroids, her color remained very dark. Even though with her ACTH coming beautifully down and mother reassuring me of the compliance, she didn't improve in terms of skin color. So ladies and gentlemen, I'll just finish by concluding that acquired lipodystrophy can be associated with extensive autoimmune involvement. And as you have seen the sequence of development of autoimmune diseases, this explains that the disease is perhaps progressive in nature. I don't know what else of autoimmune disease spectrum she will have next. And despite her extreme physical features, her metabolic findings were minimal at the moment. I don't know what will happen with her, and her leptin was normal. My question to you, do you think I should start her on leptin, which is available and it's reimbursed for her tier of insurance in Abu Dhabi? And would you think that I should perhaps do a whole exome or whole genome? I might be missing something. I did an extensive gene panel for lipodystrophy, which came back negative. And with those questions posed to you, which I don't have any answers for, I stop and thank you very much indeed.